I'm Amy Capraro and I will be doing the case study and the NSQHS standards.
Hi, I'm Karis McCarroll and I'll be talking about the nursing interventions.
Hi, my name is Rajendra Kaur and I'm going to talk about pharmacological intervention.
Go.
Hi, I'm Holly and I'll be talking about the pathophysiology of Addison's disease.
We're doing Addison's disease. This is a part of the endocrine system and this is our case study. A 55-year-old male, John Smith, presents to the emergency department. His chief complaint is that he has been feeling dizzy when he goes from a sitting to a standing position, which he's finding quite debilitating. He also states that he's been unable to participate in his usual activities because he is so fatigued and has been experiencing severe muscle weakness. He appears pale, but you note the darkened pigmentation around his lips and in the creases of his hands. While collecting a health history, he tells you that he works as an air traffic controller and mentions that at present he's off work due to a traumatic plane crash that has caused him a great deal of stress. Interestingly, he says his symptoms have increased since the event and is wondering if it could all be stress related. When asked about his diet, he states he's been having strong cravings for salty foods, which he normally doesn't like. You complete a set of observations and a urinalysis, and the results are as follows. The doctor suspects Addison's disease and orders blood tests for the patient, revealing low serum cortisol, low plasma aldosterone and hyponatremia, along with hyperkalemia, elevated plasma ACTH and elevated renin levels. For a more definitive diagnosis, the doctor also requests an Acth Stimulation test. This involves checking blood levels of cortisol first thing in the morning to get a baseline, and then administering ACTH to the patient IV and rechecking cortisol and ACTH levels at both 30 and 60 minutes after administration. If the cortisol levels remain low and ACTH high, it would indicate Addison's disease.
Addison's disease is when the steroid hormones produced by the adrenal cortex are either low or absent. Within this, there is consistent insufficient production of steroid hormones called glucocorticoids, cortisol, and mineralocorticoids, aldosterone. Cortisol is produced by the zona fasciolata of the adrenal cortex, which is located in the kidneys, and is regulated by the pituitary gland in the brain. It maintains a consistent blood glucose level, reduces inflammation, and regulates water balance. Aldosterone maintains sodium and water balance, which are necessary for keeping consistent blood volume and pressure. There are two types of Addison's disease: primary and secondary adrenal insufficiencies. Firstly, there is primary adrenal insufficiency, in which antibodies are sent to attack the host cells of their adrenal cortex and are destroyed, which results in cortisol not being produced or insufficiently. Causes are 80% due to autoimmune response, in which the body's immune system mistakes its own cells or biochemicals for pathogens. Adrenal dysgenesis, a genetic disorder in which the adrenal glands aren't formed properly. Difficulties in converting cholesterol to steroid hormones. Infection from HIV or tuberculosis, and other diseases that impair the adrenal cortex. Secondary adrenal insufficiency is the hyposecretion of pituitary ACTH, resulting in hypersecretion of cortisol. The production of aldosterone is not affected, and therefore symptoms that occur to an absence in aldosterone are not commonly presented. Causes are necrosis or bleeding, long-term glucocorticoid therapy, pituitary tumor. Addison's disease can also occur after a patient stops taking steroids, especially taken after a long time or in high doses. Also, upon sustained use of hydrocortisone and prednisone can cause an iatrogenic response, which is an instance where treatment causes a disorder. The prolonged treatment can desensitize the adrenal gland that normally stimulates cortisol production, which causes itself to shrink and impair its ability to make natural steroid hormones. The symptoms of Addison's disease are as follows. For the hormone cortisol, it usually keeps blood sugar levels in balance by stimulating the creation of glucose in the liver, and therefore an absence is a drop in glucose. Also, it is in charge of the stomach digestive enzymes. The symptoms of a lack of cortisol are fatigue and lethargy, and in very low cases can lead to coma, and in most serious cases, death. Also, vomiting, diarrhea, and cramps. Cortisol and aldosterone work together to maintain salt and water balance. A symptom of low cortisol and aldosterone is orthostatic hypotension, which is a sudden low blood pressure that occurs on standing. Aldosterone alone is responsible for water and sodium balance and fluid volume. Symptoms of low aldosterone is nausea, diarrhea, and vomiting due to the water and sodium loss, and in most serious cases, shock due to the fluid volume loss. Further signs and symptoms are dehydration and hypovolemia, which is low blood volume, potential reduction in muscle and nerve function due to reduced sodium and potassium, heart arrhythmias, nervous system changes, especially in the form of mood disorders, are common. Craving for salt, as seen in the case study, in effort to replace the sodium being overexcreted in the urine. Flimsy body hair, brittle nails, hyperpigmentation, as identified in the case study, which is the darkening of the skin in places not necessarily exposed to the sun, like palms or in the cheeks. Normally, the anterior pituitary gland sends adrenocorticotropic hormone, also known as ACTH signal, to the adrenal gland, signaling to release glucocorticoids. Once there is an increase in the blood, the pituitary stops releasing ACTH. However, in Addison's, there are no cells to respond to ACTH, so the pituitary sends out more and more ACTH in an effort to get the adrenal gland to make glucocorticoids. Some of the ACTH that accumulates is turned into melanocytes that stimulate production of skin pigment. Intraoral hyperpigmentation is the initial sign. There is also blood abnormalities, hypoglycemia, hyponatremia, hyperkalemia, increased white blood cell count, acidosis due to an increase in hydrogen ions in the blood. Potential complications. Risk factors are comorbidities like type 1 diabetes, hypothyroidism, unmonitored or prolonged steroid use, and hypotension. Dysfunctional state of condition is hypotension, which can progress to vascular collapse and shock. Addisonian crisis, which is life-threatening symptoms that occur due to a lack of cortisol. They experience weakness and mental confusions, abnormal heart activity, fever and abdominal tenderness, sudden drop in blood pressure, convulsions, and coma. Treatment must be immediate, and it usually involves cortisol injection and fluids to stabilize fluid and electrolyte balance. Lastly, as cortisol plays a role in mediating stress, people with Addison's need their holistic health to be monitored during these times of stress, as mental health can be affected. Many people with Addison's disease experience reduced motivation, behavioral disturbances, mood disorders, and even depression.
The nursing interventions that will be conducted on John are vital signs that should be done every 4 to 6 hours. The rationale for this is that it monitors for deterioration and gives an indication of the hemodynamic status, which is a problem with Addison's disease. John will require this because it will detect and pick up minor changes early to prevent deterioration. The potential problems that the patient presents with are hypotension. Therefore, respiratory and heart rate will be risen to compensate for low blood pressure. Based on the first set of observations that have been done on John, this has already started to happen. John is fatigued and has muscle weakness. and he also has salt cravings, which is all indicative of low levels of sodium in the blood, which leads to mental confusion. The potential problems with this is that if the patient has anything less than 15 on the BCS, they're at risk of an altered state of conscious. The nursing interventions to treat this would to be conduct a Glasgow Coma scale, and this would be done because having Addison's disease puts you at risk of an altered state of conscious. John has presented with abdominal pain for investigation and has a high temperature, which is a symptom of infection. The potential problems for this is that the patient could have glucose or infection in urine. A nursing intervention to treat this would be to complete a urinalysis on admission. This is done to give an indication of current renal function status, as excessive leukocytes in urine are an indication of infection. This will also involve a pathologist who would investigate abnormalities that present in the urine. John has presented with fatigue, muscle weakness and salt cravings, and the potential problems with this is that if the patient has electrolyte imbalance, he will become hypo or hyperkalemia, leading to heart arrhythmias. A nursing intervention that should be conducted is electrolyte imbalance, should be assessed every 30 minutes to 4 hours for the first 24 hours, depending on John's instability. This will be done through blood tests assessing urea and electrolytes. This is done so that the electrolyte imbalance is symptomatic of Addison's due to the lack of hormone secretion, and this will require a pathologist to read and interpret the blood tests taken. John is presenting with fatigue and is also pale. A potential problem with this is that he could develop an altered state of conscious and collapse. A nursing intervention to treat this would to complete a full blood examination with specific attention to his hemoglobin level, and this is done because fatigue is a clinical manifestation of low hemoglobin. Anemia is suspected and is confirmed by a blood examination. This will also involve a pathologist to read and interpret the blood tests taken. John has presented with postural hypotension, which is an indication of circulatory volume deficit. A potential problem for this is that John may become dehydrated and can possibly go into shock. The nursing intervention to treat this is to monitor signs of fluid balance volume deficit. These signs will be seen in the patient having hypertension, and this will be done by keeping a fluid balance chart and daily weighs. The rationale for this is that monitoring fluid volume helps monitor for deterioration in fluid balance volume. John is on steroid therapy and is at risk of his BGL rising. The potential problem for this is that his BGLs can rapidly increase if it's not monitored. A nursing intervention would to monitor it 3 times a day. The rationale for this is that certain types of steroid therapy can affect BGL even if they do not have diabetes, and this will involve the doctor that prescribes the steroidal therapy. John has presented with fatigue and muscle weakness and will also be able to manage hygiene and will not be able to manage his hygiene on his own. A potential problem of this is that his skin integrity can become compromised, and so the nurses should give assistance with daily hygiene so that the patient maintains his skin integrity, as poor hygiene can open the doors to infection. John has a high temperature, which is a symptom of infection. A potential problem with this is that the patient may become immunosuppressed. A nursing intervention for this is to protect the patient against exposure to infection, and the rationale for this is that infection is a risk from corticosteroid therapy. John has presented with stress and lack of sleep. A potential problem of this is that he can be faced with overwhelming amount of stresses. The nurses should protect John from noise, light and environmental temperature extremes, as he has an inability to produce corticosteroids, which means he cannot tolerate stress. John has a salt craving, which means his sodium and water levels are too low. A potential problem is that his sodium levels can become too low and he can become extremely dehydrated. The nursing interventions for this is to monitor salt intake and make sure it's adequate and that he's being administered IV fluids. The rationale for this is that sodium levels may get too low if your body is losing too much water, and this should involve a dietitian that the nurse should refer John to, as the dietitian will enable John to receive an adequate sodium intake.
Treatment for the Addison disease is hormone replacement therapy. Adrenal cortex produce hormone as known as corticosteroids. There are three types of corticosteroids: androgens, glucocorticoids, and mineralocorticoids. Hydrocortisone, cortisone, and prednisone have glucocorticoids and some mineralocorticoids activities and effect. There are a few medications that can be used to treat this disease. Number one is hydrocortisone. Number two is fluorocortisone. Number three is prednisone, and number four is cortisone. All of these medications are available in injections, IV, topical, and orally. If patient can't retain these medication orally because of vomiting, then these medication can be administered by injections or IV. Drug interaction and adverse effect of for Addison disease. Corticosteroids may diminish therapeutic effect of vaccine and increase risk of adverse effect. So vaccine should be avoided for at least 3 months after cessation of corticosteroid therapy. Common adverse effects are adrenal suppression, congestive heart failure, delayed wound healing. Hypertension can be occurred due to high doses, increased white blood count, sodium and fluid retention, peptic ulcer development, osteoporosis, hypoglycemia, and diabetes mellitus. Steps for safety monitoring. Administer medication on time and do not skip the dose. Check vital signs prior the medication administration, because high doses of hydrocortisone can cause hypertension. Always keep on an eye on blood glucose level. Monitor sodium and fluid retention, potassium and calcium depletion. Monitor response to drug and adverse effect. It is important to instruct the patient to inform other healthcare providers such as dentist about the use of corticosteroids. Need to protect from exposure to infection. Instruct the patient to wear a medical alert bracelet and carry all the information at all times about corticosteroids. Family members should know how to inject the injection in case of an emergency. Patient need to register with ambulance as a Addison disease. So in case of emergency, they can bring the injection along with them. Patient should keep extra medication all the time, and patient should stay in contact with doctor. So, I think I forgot.
The NSQHS standards that we thought related to the case study was Standard 4, which is medication safety. This would include using the 7 rights of medication administration: right person, right route, right dose, right drug, right time, documentation, and reason. Standard 5 was patient identification and procedure matching. This would mean correctly identifying the patients and their procedures using their wristbands, UR numbers, date of birth, photo ID on charts, medication chart information, and other labelling. Standard 6 would also apply to this case study. When handing over to other nurses or the next shift, the staff would use the ISOBAR framework, which includes identifying, describing the situation, handing over current observations, giving background information, the assessments that have been done, and then requests for follow-up.